thank you very much for inviting me to speak. My remit was to update you on the NICE pressure ulcer prevention guidelines. Some of you that were at the Tissue Viability Society conference last year will know I presented some information about the guideline at that stage. And you'll also recall that when we volunteer to be members of the guideline development group, we have to sign our life away in blood to say that we'll not disclose anything about the guideline until it's absolutely published. So I'm here to talk for half an hour about something that I'm not allowed to talk about. So I'll see you later. Okay, so I'm just going to give you a little bit of an update on things that I can discuss, and what I'm hoping to do is maybe generate a bit of discussion, and I'm going to talk to you about some of the other information and publications from NICE, which we might find of interest, and we might lead to some discussion later on in the session. Okay, so we'll talk a little bit first about the new pressure ulcer prevention guideline, because I know that's what you're all interested in. I won't go into too much detail about the background of it and the methodology for developing the recommendations. They are very similar to what Liz has described in the international guidelines, in that we use the grade system to evaluate the quality of the evidence and how much weight we apply to that evidence in terms of making our recommendations. So there is very, very strict criteria which has limited us in a lot of the recommendations that will be made, as you will see in the not too distant future. So this is where we are in terms of the timescales now. Hopefully you will have all seen, those people in the UK, well in England anyway, the consultation document that came out in November. Hopefully some of you will have contributed to that consultation. Anybody registered as a stakeholder, similar process as with the international guidelines, you need to register as a stakeholder before they will accept your comments. And that consultation process closed. I think it was a bit cheeky of them, really. It came out sort of, as I say, the end of November and closed the 6th of January. So you had plenty of time to make your comments over the Christmas period, when we all had lots of spare time, didn't we, to comment on this, which I thought was a bit cheeky, really. But anyway, it's done. Consultation has taken place. We've got a record now of all the comments people made, and that was discussed at a final guideline development group meeting in January that I attended. And now the NICE people are collating all those, accepting or rejecting the comments, and producing the actual guideline. And the launch date, we were told, was May 2014. If you look on the NICE website, it says April 2014. So even I don't know when it's going to be launched. We're hoping. I think it will be very early May. Just to remind you, I'm going to give some of the things that came out on the draft consultation document. I can't tell you, because my lips are sealed, what the final document will say. But I can tell you some of the stuff that is public, which was included in the draft consultation. But because this is draft, bear in mind some of the recommendations will change slightly. The principal things will not change. Mainly, it was just changes in wording and phrasing of the recommendations. Just to remind you, though, the scope of the guideline. And I discussed this last year. And specifically things that are not included in this guideline. So I'm very pleased to see medical devices in the international guideline. We were not allowed to consider any evidence or make any recommendation about medical devices, which, as many of you working in clinical practice will know, is proportionally becoming more of a problem as we're managing to crack the immobility traditional bed sores. We're having more of an issue in terms of managing our device-related pressure ulcers, but it does not include any recommendations about those. Before we look at what the recommendations say, you need to be aware of the wording of NICE, and they're very pedantic about this. There's very odd words used, and they have very, very specific meanings. So people often think that, that's a funny thing to say, is offer something to a patient. But these words have been produced to enable us to be clear about this comes from a patient-focused recommendation, that the decision to treat or apply a prevention process should be done in consultation with the patient. so that we don't do things to patients, we offer treatments and interventions to patients. So that's why you get those sort of wordings. You'll very rarely see a nice recommendation that says must or must not do. The only time you'll see that is if there's legal implications, or if the evidence says that it will really cause harm to the patient, then you might get a recommendation saying must not, but otherwise you'll never see those words. The should or should not, if there's good evidence, good RCT evidence for an intervention, you'll see a recommendation that says should or should not. And you'll probably find that there's very few recommendations in the new pressure ulcer guideline that say should or should not, based on the lack of good quality evidence in favour of one treatment or another. There's quite a bit of evidence out there. There's a lot of papers to review, but often the difference was very small, such that we couldn't make a strong recommendation. Consider is used throughout the recommendation, and this is used when we've looked at the RCT evidence. It suggests that it might be beneficial, it suggests that it might be cost effective, but it's not the only possible treatment that you might want to use. So the words consider means that you should consider it when you're having your conversation with your patient about how you're going to manage the pressure ulcer prevention or treatment. So again, the focus is about a joint discussion with your patients to find the best treatment that suits them. Okay? So I'm just going to go through some of the things that you're likely to see. Remember, I haven't told you this. This is just what's pulled from what was on the draft consultation. So you need to watch this space for the final document. So it'll ask us to risk assess all patients admitted to NHS care. And that's based on the evidence. I think that probably is not a surprise. Most people do some form of risk assessment, but some of us screen every patient and then only do a full risk assessment on certain patients. So it's likely that we're going to be recommending that every single patient who is admitted will have to have a risk assessment. Okay? And then this was a controversial one. We spent hours and hours discussing this. Patients who come under other NHS care where they're not admitted to hospital. So this could be community nursing, NHS care in care homes, GP surgeries, outpatient departments, A&E departments. So any non-inpatient NHS care, patients who have certain risk factors must have a risk assessment. So that's the distinction. So we had a lot of debate about how GPs were going to risk assess these patients, and we think there might be a huge training implication for GPs. I don't know if any of you agree with me on that one. I think there's going to be a bit of controversy over this. The recommendation will be to use a validated risk assessment scale to support clinical judgment. No surprises there. Offer skin assessment for those at elevated risk. Now this term elevated risk, on the consultation there was a lot of comments about the term elevated risk and what this means. So it might change, okay? I'm saying nothing more. The term elevated risk. Skin assessment, I think it's unlikely that the recommendation will be that every patient has to have skin assessment, but there will be a recommendation about skin assessment for certain patients. And that skin assessment will include looking for, asking the patient about pain and discomfort at the pressure area site. Part of the skin assessment will be about determining erythema and blanching and non-blanching erythema. And if non-blanching erythema is present, they suggest that you should reassess the skin up to 2 hourly. They recommend individualised care plans for those at elevated risk, no surprises there. Repositioning 6 hourly for those at risk, and repositioning at least 4 hourly for those at elevated risk. And this is in all care settings. They are, as part of the process, they do look at the cost implications of implementing these guidelines. And the last time the guidelines were produced, the cost implications document suggested that all the recommendations were standard practice and there would be no cost implications. It'd be interesting to see what the final cost implication recommendations are on this one. No surprises, don't offer skin massage and rubbing. Do not offer additional hydration or nutrition where this is adequate. Some of these recommendations, you'll need to read the wording very carefully, because we're not saying don't offer hydration and nutrition. We're saying if the hydration and nutrition is adequate, don't offer any additional. There's no added benefit to extra nutrition and hydration, or no evidence of any added benefit. Okay. In terms of preventative support surfaces, high-spec foam mattresses for secondary care, and for those patients at elevated risk in community, and consider those at elevated risk for going for surgery. So there's no recommendation for dynamic mattresses based on the lack of evidence for the dynamic mattresses. The recommendation was high-spec foam mattresses. There are specific recommendations for heels about offloading the pressure, and consider high-spec foam cushions or equivalent for wheelchair users. Again, I need to emphasise these are the draft guidelines for consultation. There may be some changes that come out in the final guideline, but I don't know what those will be. Consider using barrier preparations for those at elevated risk of moisture lesions. Children, recommendations for children. As you're probably aware, there is very little research evidence for pressure ulcer prevention in paediatrics. So what they decided to do was do a Delphi survey of staff across England who were involved in care for paediatrics, and we basically devised an online questionnaire which was sent out to stakeholders who worked with paediatrics, and to produce some recommendations for the prevention and management of pressure ulcers in children. And although they're listed separately, or they will be listed separately in the final guideline, the message is pretty much similar to what the recommendations for adults. There will be recommendations about patient and carer information. We did have 2 patients on the guideline development group. They both happened to be patients with from the Spinal Cord Injuries Association, so they had very good experience, but in a limited field as patients. But they were very, very helpful in terms of challenging us on some of the things that we were saying we thought should be included. There are recommendations about training and education for healthcare professionals who come into contact with patients at elevated risk. And I don't know if any of you are at this stage that I am in my trust with trying to engage with the medical staff, because they come into contact often before the nurses do of patients at elevated risk, and we are putting together training packages for the medical staff at the moment, and we are putting certain groups of doctors who work predominantly, for example, stroke and vascular, putting them through a competency assessment for skin assessment, and I think this is going to be endorsed with the recommendations in the guideline. Some recommendations, that was all about prevention. There are some recommendations about pressure ulcer management, and no surprises, measure and categorise the pressure ulcers. It doesn't recommend a particular scale, I don't think, but suggests something like the NP-UAP, EP-UAP grading scale. There'll be advice on nutrition and hydration to correct deficits for those with pressure ulcers. So the evidence for treatment of pressure ulcers in terms of nutrition and hydration is a little bit stronger. So the recommendation is a little bit stronger for the pressure ulcer management rather than the prevention. For patients with pressure ulcers, recommending high-spec foam mattresses, but consider dynamic mattresses, and do not offer standard spec foam mattresses for those with pressure ulcers. Do not routinely offer topical negative pressure therapy. And you'll see this term a lot in NICE guidelines, do not routinely offer. So it means that we can't say never use, but what we're saying is standard treatment shouldn't be this therapy or this intervention. And do not routinely use topical antiseptics and antimicrobials. So that's just a little taster, and I have to keep putting this disclaimer in because I'm not supposed to tell you, and really honestly I don't know what the final document would look like. This is just a taster of what is likely to be in the guidelines. So you need to keep a lookout. The end of April, beginning of May, these guidelines hopefully will be in the public domain. So that was just a little short, I've got some more time, so I thought it might be worth just having another look at some of the information that's on the NICE website to do with tissue viability. So the NICE website has lots of resources. It has clinical guidelines, guidelines on diagnostic procedures, what they call highly specialised technologies, interventional procedures and medical technologies. So there's clinical guidelines and then there's guidance on all those other elements of the clinical guideline part of the website. So I'll come on to that in another few minutes, just bear with me on that one. They also have what's called quality standards, NICE pathways, and into practice, and the quality outcomes framework, which is a voluntary incentive scheme for GPs. So in terms of the actual guidelines that are tissue viability related, and I'm just recapping this from last year. I think I checked, and I think my presentation from last year is still on the Tissue Viability Society website. If you're members, I think you'll still be able to see that presentation from last year. But the top two are the pressure ulcer prevention, pressure ulcer guidelines, which will be replaced when this new guideline comes out. There's the guideline for diabetes and the guideline for diabetic foot problems, which mention multidisciplinary team working, and the diabetic foot problems say that we should involve a tissue viability nurse as part of the multidisciplinary team. There's the prevention and treatment of surgical site infection, which has guidance about preoperative, intraoperative and postoperative management. And then there's one that I didn't mention last year that I came across, which is the lower limb peripheral arterial disease diagnosis and management, the CG147. Is anybody else familiar with this guideline? Yes. It was actually when I was working with my colleague of Nikki's that we came across this. We talked last year about venous leg ulcer guidelines. If you actually look, there is no guidance in England for venous leg ulcer management. We did have the RCN guideline, but that was withdrawn and has been archived now. And the message on the website says that there is a suite of wound management guidelines under development, but there's no further information about that at all. And it points you towards the SIGN guidelines, the intercollegiate guidelines from Scotland, who do still have guidelines on venous leg ulcer management. But this lower limb peripheral arterial disease management is the nearest thing to giving us some advice on how we manage arterial disease in terms of tissue viability. And it does say that patients should be assessed for the presence of PAD if they've got diabetes, non-healing wounds on the leg or foot, or you're going to use compression, or you think they need compression hosiery. And it does recommend that the assessment should include an ankle brachial pressure index, and it recommends that patients with critical limb ischemia are assessed by a vascular multidisciplinary team. So I had a difficulty finding the definition of critical limb ischemia. They don't define it in terms of an ABPI, but they do say that it's people with severely impaired circulation who are at imminent risk of losing the limb. So I think that gives you a good enough clinical description of those patients. So I just thought I'd share that with you. It was something new to me that I hadn't come across till I spoke to a colleague a few weeks ago. In terms of those categories, I talked about the clinical guidelines, which are the process of appraising all the appropriate RCT evidence in a very robust way with a very specific methodology. And that one of the other sections under the guidance is the medical technologies guidance. Now, some of you may have heard of the MIST therapy. This is the therapy where it's a spray of water with, what's in it now? It's saline spray, isn't it, with electrical waves or something. I don't know, it's an American treatment that we don't use in this country, and that was appraised by the technology group, and the recommendation is that it shouldn't be used in standard practice in the UK when they appraise the evidence. Now, the difference with the technology guidance is that according to the website, the manufacturer or a sponsor can request that NICE will review the evidence and produce some guidance on a particular therapy. Now, one of the therapies that's just come out as a recommendation from the technology section of NICE is on Debrisoft monofilament. And I've had some discussions with Activa, who are the manufacturers of this product, and I've been told that they were approached by NICE, that it wasn't the other way around. So I'm still unclear about the process, and it's something that I'm going to look into, because it seems that there doesn't seem to be any systematic process for identifying products or devices for which they're producing guidance on. But the new guidance does say that they recommend, that they support the use of the Debrisoft in community settings, either in community clinics or in the patient's own home, for the debridement or the removal of excess the keratotic tissue. When I looked at the review process for developing this guidance, it's a different process to the guideline development with the RCT evidence. And there is no RCT evidence for a lot of the medical technologies, and it was reviewed by a committee that didn't include tissue viability nurses, didn't even include any practicing nurses. It went out for consultation, so we all had opportunity to comment on it, but the consultation process really is about tweaking what's already written. They're not going to change their mind fully, but that's the consultation process that takes place, and there is some guidance there. But I think we need to understand in clinical practice the difference between a NICE guideline and the medical technology guidance. But it's an interesting field, and I'm sure we will see more guidance. As I've listed 2 that it says on the website are under review at the moment. I presume these will be coming out for consultation very shortly, and then there will be issuing some guidance on those in the not too distant future. It may be that we might want a bit of discussion about some of these issues when I finish talking in a few minutes. The other things are on the NICE websites, and I just picked out the ones that have tissue viability relevance. The quality standards, which are basically some measurable standards which are to help you in terms of auditing processes, and they're basically a rewording of the guidance. The surgical site infection and this new peripheral arterial disease have quality standards on the website. The pathways, again, are very similar. They're a flow chart. There's pressure ulcer pathways that are based on the old guidance. I'm sure when the new guidance is issued, we'll get a new pathway, but it's just really a flow chart which you can hover over, and it expands on a little bit more detail about how the patient should go through the assessment and management process. The interpractice is the implementation tools, and it includes costing tools. So it's a spreadsheet whereby you can put in your own numbers and work out how much it will cost or whether there will be any cost savings in your particular clinical area of work. So what can be our contribution? The pressure ulcer guideline consultation, it's closed now, but you had the opportunity to comment. The stakeholders included a lot of NHS trusts, included a lot of manufacturing companies and industry, included a lot of patient groups, and other charitable organisations such as the Tissue Viability Society is a stakeholder. And actually, because of the time of year, I think there was very few comments on the consultation. We reviewed them all in the meeting in January. The majority, I have to say, came from the Tissue Viability Society. I had to remain a bit independent of that because I'd been part of the guideline development group. Jane and a few others spent quite a bit of time looking very carefully at the guidance that was there in the evidence base. Very few comments from industry, which we were quite surprised at. And then there was other organisations like the Institute of Occupational Therapists made quite a few comments. There were some health economists who took issue with some of the health economic calculations that we'd done or the experts had done. So the opportunity for comments was there. And as I say, the comments will either be acknowledged and accepted and the tweaks in the recommendation will be made, or some of the comments were things that cannot be changed, like using the words to offer a treatment. You know, people weren't comfortable with that, but that's nice regulations. We're tied on that one. What can we do? What can you do as individuals? You can suggest topics for guideline development, and I certainly think we should be asking them to review the venous leg ulcer guidance, because we need to know that that's up to date. There's lots of new evidence, such as a clinical trial that Joe told us about this morning. We need to look out for new guidelines that are being developed. If you're not already a stakeholder, your organisation, then please get registered. If your organisation is a stakeholder, you need to make sure that when the consultation takes place, that the information comes to you to comment on in a timely way. I have to go to our quality director and say, I want to be consulted when this guideline comes out, and otherwise it can bypass me. So I'm sure that's the same for some of you, because there's lots and lots of things go through their door. It's remembering who to send them to for consultation. And then we will be part of the dissemination and implementation process, because you'll be having to use these guidelines in your organisations when they come out. So that's the end of my talk. Hopefully we've got a little bit of time for some discussion, because I'm sure some of you will like to make some comments on some of the things I've said. So thank you very much.
Thank you, Liz. That was really interesting. Can I just check, Roland, what the time is? Because that time... Yeah, we've got 7 minutes. 7 minutes. Okay, thank you. So questions for Liz, please. Heidi?
Going back to the new guidelines, suggestion that GPs, I expect practice nurses as well, will be doing a risk assessment for those that present with a risk factor.
Yeah.
Is there any guidance in the guidelines on what those risk factors might be and how to weight them?
There is the suggested examples of risk factors, such as immobility, poor nutrition, pain on the pressure area, and yeah, so there are some suggestions, but it's not a totally inclusive list. Yeah.
It'd be interesting to see the reaction to that one when that comes out.
Yeah.
Can you just say who you are, sorry, and where you're from?
Yeah, I'm Sarah Shawman, Tissue Viability Nursing Community in Warwickshire. You said the recommended risk assessment of all patients admitted to secondary care. Is there no recommendation to assess all patients admitted to community caseloads?
Only the recommendation is for NHS who are getting NHS care, but not as an inpatient. So that's patients in their own homes, patients in care, intermediate care beds and things like that. The recommendation is to assess the risk only if they've got a risk factor present.
So not all patients?
Interesting, isn't it?
Very interesting.
Could I ask a question?
Yeah, who are you?
I'm Maggie Mangan, South Warwickshire Foundation Trust in the Community Tissue Viability. I just wanted to know, really, the Medical Technology Guidance Group, what evidence do they use when they recommend something like Debrisoft? I'm just intrigued, really.
Yes, it's case study and cohort study evidence, not RCT evidence. Obviously, if there is RCT evidence there, they would use that, but they base that in that particular device, and there was no RCT evidence.
And can you look at that if you was a stakeholder? Could you look at that evidence and then ask to, give you points of view?
Could I look at it?
Could a stakeholder look at it?
Yes, absolutely. Yeah.
Okay.
Yeah.
Okay. Thank you.
I think just feeding back on that one of the issues with the technology guidance is that people don't, the stakeholder comments, the opportunity for stakeholder comments, the messages go out, but nobody makes any comments, and that's an issue. And one of the things that we agreed at the trustee meeting on Monday was that we were, because a lot of the wound care companies are using this technology appraisal process as a way we think of getting endorsement, and we are very concerned about the different standard of level of evidence, and not everybody understands there's a difference between a NICE guideline and a technology appraisal. And in fact, the NICE guidelines, we've had many discussions about the grade system, which doesn't distinguish between, essentially all of the research that we do and has been done is classed as low quality or very low quality because of the strict interpretation of quality using the grade classification. And it doesn't make a distinction, for example, between a study of 50 patients and a study of 2,000 patients. So that because of the way that grade works, all of the studies come out as low quality or very low quality. So on the one hand, the NICE guidelines have this really strict methodological process, and on the practice guidelines, but then the technology appraisal has a different, completely different approach. So the Society is planning to write to the Chief Exec of NICE in order to raise this as a concern and to hopefully to get some understanding as to why these two approaches are being used. And obviously we would then, if we get a response, we'll post that on the website and put a note out to members. Sorry, Liz.
Thank you.
More questions?
Nikki.
Hi, I'm Nikki Stubbs. I'm the clinical lead for wound care in Leeds community. Firstly, I'd like to thank you for sticking with the guidelines. I think it's really important that we've got a tissue viability nurse voice in that group. And I'm sure that your influence has been very significant. And I think one of the things, just linking into what Heidi was saying about this recommendation around GPs getting involved in terms of assessing risk, I think until we make pressure ulcers everybody's business, then we're not going to be able to impact on pressure ulcer incidents in as good a way as if it's just seen as a nursing problem.
Yeah.
And so it's more of an observation than a question. But I think one of the things that hopefully this guideline will do will make people like NHSE wake up around recognising incidents that are going through from Datix, for example, that we submit all the time, where patients are referred with pressure damage from GPs into community, and then they become somebody else's problem.
Yeah.
So I think it's really important that we get our medical colleagues to pick up on these risk factors.
Absolutely, and the guideline group were really supportive of this. Unfortunately, we had no GP on the guideline development group. We put loads and loads of pleas out via various different routes to get a GP on the committee, but we didn't have one, which was quite sad, really. Just going back to the lady's comment about only assessing those at risk in district nursing, a patient who is immobile is deemed at risk, so you'd be assessing all your immobile patients.
We assess every patient that comes onto the caseload.
Yeah.
We look at risk factors, every patient that's admitted.
Okay. And there won't be a problem with that. I mean, that's.
Why that hasn't been recommended.
I think. Yeah, I think we had lots of debate about the resource implications of that, and I know there are some district nursing areas where that would be, would require 2 or 3 times the staffing resource.
Implication of treating grade 3 and 4 pressure ulcers.
Absolutely, yeah.
Okay, I'm sorry we've got to close this session now, so can I ask you all to thank Liz and